Okay, so we'll start with our first presentation today. It's Sonia Koning, who's come all the way over from Eastern Health to give this presentation, so thank you very much. And she'll be telling us about the clinical care standards and keeping some patients informed in a survey that they did earlier or late last year. Thank you, Sonia.
Right. Thank you, NCAS, for inviting me to come and present some of the work that we've done at Eastern Health. So I'll just say that this presentation was presented at ASA in February earlier this year. So this is pretty much the same presentation. So just getting straight into it. I'm sure none of us in the room need to know about the fact that antimicrobial stewardship is actually part of hospital accreditation. So we do have our own criterion with relevant criteria that we need to meet hospital accreditation. So with the AMS clinical care standard, this was actually an additional document that was produced by the Australian Commission that has 9 quality statements. And this is to ensure that patients with bacterial infections actually receive optimal antibiotic therapy. Locally at Eastern Health, what we did was we actually performed a gap analysis of our antimicrobial stewardship program, and we obviously looked at the NSQHS, the criteria. We actually looked at the 9 quality care standard statement, sorry, the 9 quality statements in the clinical care standard, and then we actually looked at specific recommendations from our previous accreditation. And some of the main recommendations from previous accreditation was they wanted a lot more consumer focus with our antimicrobial stewardship program. So just to set the background for those that don't know about Eastern Health, we're actually a large metropolitan health network in Melbourne. There's a picture of our new hospital, our new Box Hill Hospital that was actually built and opened in 2016. So our old one's still in use as well. But Eastern Health has 7 hospitals, of which 3 are acute hospitals, and we've got 3 ED departments as well. And it makes up approximately 1,000 inpatient beds. We have electronic prescribing at most of our sites, and our AMS program actually oversees the entire health network, so we are quite busy. Similar to other AMS programs around Australia, we conduct post-prescription reviews at Eastern Health. We do regular education with nursing, pharmacy and medical staff. We do dedicated audits. As you can see, we participate in all the NAPs, including hospital aged care, the surgical NAPs. We participate with FICNIS as well, so and the NORSE program. So we're doing a lot of the things that other hospitals around Australia are already doing. When we were looking at the clinical care standard, so we obviously looked at the indicators that were presented in this document, in the indicator specification guide. And as some of you may be aware, a lot of the quality statements in the clinical care standard actually don't have a recommended indicator to measure against. So this is just a snapshot of the AMS clinical care standard, and what was really clear to us was we were managing the quality statements quite well. The 2 main gaps that we had were around quality statement 3 and 5, and this is around the provision of information regarding infection and antimicrobials to our patients. So statement 3 being a patient with suspected infection and or their carer receives information on their health condition and treatment options in a format and language that they can understand. And statement 5 being when a patient is prescribed antibiotics, information about when, how to take them and for how long to take them, as well as potential side effects, and a review plan is discussed with the patient and or their carer. So this was a clear gap for us that we identified when we were conducting our gap analysis. So locally we decided we would address it because we had upcoming accreditation. So our full hospital accreditation occurred in March early this year. So what we actually did was we actually developed a verbal sort of interview style survey, and this actually went through ethics, it went through our AMS committee, and it had consumer input as well. And what we included were hospital inpatients and all their carers. So we actually have paediatric patients at Eastern Health. So we actually did have an opportunity to speak to parents and carers of paediatric patients. We included our acute and subacute patients in various sites. So we conducted this survey across most of our 7 hospitals within Eastern Health. Patients had to be on the antimicrobials for greater than 72 hours, and it had to be a new course. So if patients actually came in on antibiotics and it was this part of their regular medication, we didn't actually survey those. So these were new courses of antibiotics. Given that it was a verbal survey, we obviously excluded patients that were unable to speak English or if they had cognitive impairment. So they were exclusion criteria. So in terms of results, we actually managed to survey 142 patients across the health network, and we managed to capture a vast variety of different units, different ages of patients. So the results, what was demonstrated was 83% of our patients actually had someone, a staff member, actually explained to them that they were actually on an antimicrobial. 96% were actually aware they were on an antimicrobial, even though there was no discussion. They knew because obviously the nurses would come and just hang up the antibiotics. 58% were informed on when and how to take the antibiotics, and 58% were also informed on when the next review or what the duration would be of the antimicrobials. What was surprising to us was that 77% of our patients were actually quite happy with the amount of information that they received, and they didn't actually want additional information. So of the 117 patients that were actually informed that they were taking antimicrobials, only 22% actually had treatment options explained. So in our survey, we do ask them whether treatment options were actually explained to them, including the option of not receiving antimicrobials, as this is actually part of the quality care statement. Only 4% had written information provided to them, so this was definitely an area for improvement for us. 31% were informed of the actual the duration of antimicrobial of the course, and only 26% had side effects explained to them. So for us, we felt that these results were quite poor and definitely an area for improvement for us. So the next question we had was, well, who was actually giving the patients all this information around antimicrobials? Oops. So about half of our patients actually said it was a combination of the doctors and nurses that were actually providing the information around the antimicrobial therapy. A third said it was just the doctors, 14% said it was just the nurses, and very sadly, being a pharmacist, only 1%. So just bear in mind, this was the inpatient setting, and we know that often pharmacists are involved with the discharge counselling of medication. So some of our patients actually told us that, even though when we asked about the pharmacist, they did say that, for the patients that were sort of frequent flyers, they knew that on discharge they would see their pharmacist and they would get more information from their pharmacist. So what were our patients actually telling us? So this was one of the questions we had in the survey. So whilst in hospital, did a staff member discuss treatment options for your infection with you or your carer, including the option of not giving antibiotics? And you can see some of the patients just said, I was just given them, I'm unsure why I'm on them. I just take what I'm given. And some just said, I don't have an option, but to have antibiotics. So it was clear to us, our clinicians weren't actually explaining the risks of having antibiotics versus the risks of not having antibiotics. Another question we had was, is there any other information you would have liked with regards to antibiotics? And this was some of our responses from patients. So no, just swallow them and hope for the best. I trust what the doctors know what they're doing. Some patients said, I've been on and off antibiotics for quite some time. I'm happy to be on them if it helps, but I trust the doctor's judgment. And this comment I thought was quite interesting, which really, strengthens, the need for IV to oral switch is a patient wanted to know when they could be changed from IV to oral because they were sick of being woken up in the middle of the night for their IVs. So when we looked at all the comments from our patients, there seemed to be a lot of trust in the doctors, and they just sort of trusted what the doctors were prescribing them and believed that that was the best therapy for them. So just in discussion, this was a very labour-intensive survey, I guess. We are quite fortunate. We've got an AMS technician at Eastern Health, and she actually conducted all the surveys, and to get the 142 patients, it did take several months to achieve. Given this was the first time we were doing it, we wanted to get decent numbers to actually use this information to inform future direction for our network. So as I mentioned, only inpatients were surveyed, and we decided to do this because we know that there's a lot of discharge counselling that occurs at discharge. We weren't quite sure when patients would be discharged, so timeliness was something we took into consideration when we were developing the methodology. And obviously being an inpatient, we sort of almost have a captive audience, so we could actually get more information from our patients. And we know CMIs are usually provided on discharge, and we wanted to know if any written information was being provided when patients were an inpatient. Obviously, we need to consider recall bias. So, whether the patients actually were told the information, they just forgot about it. That we know that happens. Patients being in a hospital, they're in a different environment. They may actually not remember what they've been told. There's so much going on for them. We know that the results might be different had it been a written survey, but we were conscious that we wanted it might be a low return rate or low response rate had we sent out written surveys. So obviously being a verbal survey, it was very biased towards English speaking patients, and this is something we take into consideration given at Eastern Health we do have a lot of patients that are from non-English speaking backgrounds. So that's something we're sort of parking on the side, but we are considering for future development. And the issue about empowering the patient. So from our results, it seemed like a lot of patients trusted the doctors, and it didn't appear that they were wanting to be, taking responsibility for treatment plans. But as we know, with accreditation standards, we're really moving towards, consumer participation in terms of consumer decisions as well, involving the consumer in decisions in treatment. So this is just something we're keen to sort of look into a bit more. So just to conclude, we've actually since sent all these results back to our medical staff, our nursing and pharmacy staff. Pharmacy were a little bit shocked with the results, but this is definitely room for improvement. It was our first sort of pilot project. We've in the process at the moment, we're actually developing an e-learning module that actually incorporates all the AMS clinical care standards, and we're hoping to have that done and rolled out across our health network for medical, nursing and pharmacy staff. And that includes what type of information these clinicians should be giving to our patients. We've reviewed the actual survey tool, so we're sort of in the second revision of this survey tool. We're trying to get more qualitative information from our patients because we really want to know what information do our patients actually want. The fact that 77% of our patients were quite happy with the content that they were provided, even though we felt that the content that they were provided with was quite minimal. So, what information do they truly want to help them, make informed decisions? So that's something we're looking at the moment. We're also looking at having more written information to actually be available for staff to actually give to patients, especially while they're an inpatient. And we're quite keen to look at, review barriers in providing patients with information. So what's actually stopping our clinicians from actually giving them all the information that's required? So I'd just like to acknowledge our AMS team at Eastern Health. So Kim Wangman, who is our fabulous AMS technician. I believe my AMS team is actually tuning in, listening to this presentation. So, so I have to definitely shout out to them. But Kim was, she pretty much she had to do all the surveys and listen to all the life stories of our patients. So there's a lot of work done by Kim and Kylie, Lindley and Mary, who were part of our AMS team, who helped with the development of the survey, as well as looking at the results. So with that, I'm happy to take any questions.
Sonia, with the poorer responses, so giving out the patient information sheets from the antibiotics, did you actually have those provided, ready to be handed out, or that's kind of up to the nurses or pharmacists? As in, at the time of the survey, do you mean? Or? Yeah. So no, so Kim did all the survey, and we specifically chose to have Kim to do the survey because I think, so when having a pharmacist do the survey, I suppose if a patient starts saying that I wasn't told about side effects, I wasn't told about this and this, as a pharmacist, I would feel obliged to start telling them, more information. So we purposely had the technician do the survey so it wouldn't sort of bias the results, if that makes sense. We've acknowledged that we don't have much written information, but we're using external sources, as I'm sure most health networks are, from MPS, CEC, NCAS. There is a lot more information coming out, but there's probably still not sufficient information available, written-wise, to give to our patients. So, yeah, it's a bit tricky. And the same point with the duration. Yeah. Do we know that if that was not provided because the doctors didn't know the duration they were intending to provide? Yeah. It just wasn't passed on? We're not, we don't know. So at the moment, we're actually trying, because we've got 142, results. We're actually in the process of actually going through our data set, looking at gender, age, to see if that actually makes a difference on whether patients were given more information or whether they wanted more information. So I think that will be quite interesting, because I think we can assume that young people, maybe our young consumers, might actually ask more questions so they get that information, whereas our elderly patients, they might sort of just trust the doctors and just, not ask questions and be happy with whatever treatment they're given. So that's something we're in the process of doing as well.
Probably just on that last one, just looking at the ages with the responses might be interesting.
Yeah, so yeah, we're literally in the process of yeah.
Just to pick up on your point around the pharmacist role, for me, not having worked in the hospital for a long time, so is it that at your health service, every patient that's discharged might expect, or you would expect to see a pharmacist?
Yeah.
Weekends
included? Yep. So with our pharmacy service, admission and discharges are sort of the key sort of things that they have to do. Because we have moved away from paper charts, I think back in the day when I was a clinical pharmacist on the ward, when you went around and you sort of did your paper chart review, you'd actually see the patient and you could almost say, oh, Mrs. Smith, you've been started on this antibiotic, and you sort of have that conversation. We feel that since moving towards electronic prescribing, there is a lot more working on a computer, especially in the inpatient setting. So that might have a bit of a slight disconnect to the patient. That's what we feel. We don't know for sure during their admission, but definitely at admission, they definitely speak to a pharmacist. And I mean, if an antibiotic's been started at that point in time, that is definitely an option to have that conversation about the antibiotics. And definitely, I know at discharge, often they're given CMIs if there's not already a information leaflet in the box of the antibiotics. Yeah.
Also, with that low pharmacist rate, do you have any thought that maybe they just thought that the pharmacist was a nurse?
It could be. I'm not too sure. They're not in uniform, so it's hard to just. I mean, our nurses, they're in uniform, so that could. I mean, I would assume, but again, we can't assume anything. That they could tell the difference between a nurse and a pharmacist, because our nurses do wear uniforms in the hospital.
Do you think nurses could have a potential role in communicating with patients?
I 100% think that nurses play a very important role in informing our patients around their antimicrobial therapy. If they are hanging up the bag of Tazocin or whatever it might be, like, that's a great opportunity to actually have that conversation. Mrs. Smith, you've been started on, piperacillin tazobactam. This is a penicillin. We're using it for your diabetic foot infection or something like that. So I think it'd be a great, opportunity for our nurses to have that conversation with the patient. So, yeah.
Sonia, I've got one more question.
Yeah.
The GPs is there any communication beyond the hospital setting to the GPs?
Yeah. So, I mean, they get their discharge summary. The GPs get the discharge summary. But yeah, so we only looked at inpatients for this particular project. There's been discussion with pharmacy about potentially rolling out to an outpatient setting, but obviously that's harder to capture patients, obviously, once they've been discharged. Yeah.
No questions. Thank you.
Thank you.